So, Carlos, where were you when you got the news of the verdict in Minneapolis?
I was on a live panel discussion, and the Good Morning America anchor, Robin Roberts, we were on together, and she read it out loud. And probably like you, I had a whole mix of thoughts and emotion. Where were you?
I was getting ready to go on air, and then we realized we were going to get the verdict because we were given an hour's heads up. So we decided to go on air much earlier. But it was so interesting talking to our reporter up in Minneapolis, because just before the verdict was announced, you could have heard a pin drop in that city. And then, of course, once the verdict was announced, it was a huge outpouring of emotion. And I'm not going to use the word jubilation because it wasn't jubilation. It was much more mixed than that. But there was so much more emotion in the streets of that city once the verdict was announced.
You know, Katty, it's so interesting as we sit here and talk about that. I now have had so many instances in my life where I've been part of the crowd waiting to hear about a court decision, usually on a killing. And, you know, what an interesting time and window that we're in, and all the various conversations, including about life and death, are so present.
Hello, I'm Katty Kay in Washington.
And I'm Carlos Watson in California.
Welcome to When Katty Met Carlos,
a new podcast exploring what's shaping America today, brought to you by the BBC World Service and OZY Media.
It's been quite a year.
Scientists in China are trying to determine if a new virus strain is responsible for a pneumonia outbreak in the city of Wuhan. At least 59 people are believed to have been sickened by the new virus.
That was back in early January of 2020, and it wasn't long before COVID-19 reached America, even if some people seemed unconcerned.
The first case of China's new and deadly coronavirus has been reported here in the U.S.
We have it totally under control. It's one person coming in from China, and we have it under control. It's going to be just fine.
As we know, however, there was one direction of travel for coronavirus, and it wasn't good.
The U.S. Embassy in Beijing confirmed overnight that the first American has died from the virus at the epicenter in the Chinese city of Wuhan.
And so far, we have lost nobody to coronavirus in the United States. Nobody.
Breaking news. The first death from coronavirus here in the United States. A man in his 50s dying from COVID-19 infection in Washington state.
Today, I am officially declaring a national emergency.
Coronavirus! Coronavirus!
Anxiety about the outbreak was growing. The rapper Cardi B's message to her millions of Instagram followers quickly went viral. And the numbers kept going up.
We are interrupting our normal programming to bring you the breaking news that President Trump and the First Lady have tested positive for the coronavirus.
The nation hit another record Friday with more than 205,000 new infections. That is a single-day high, with many states not even reporting.
Tonight, the country is commemorating the more than 500,000 people in the United States who have lost their lives to COVID-19. The bells at Washington's National Cathedral are set to toll 500 times, once for every 1,000 lives lost to the virus.
Today we mark a truly grim, heartbreaking milestone. 500,071 dead. That's more Americans who have died in 1 year in this pandemic than in World War I, World War II, and the Vietnam War combined.
That figure now stands at more than 560,000 deaths. It's a big number to get your head around. So how does a nation, a community, a family process all of this?
Our guest this week has made the study of death and dying something of a speciality. Dr. Atul Gawande is a surgeon at Brigham and Women's Hospital. He's also a professor at Harvard's Chan School of Public Health and the author of Being Mortal, a best-selling book about how we deal or we fail to deal with the end of life. He also served on President Biden's COVID-19 advisory board. Dr. Gawande, welcome to When Katty Met Carlos.
Thank you for having me on.
I wonder, when you listen to that recap of what the country has gone through in America and how many deaths we have had, how you think the nation has faced this pandemic. I'm torn between thinking we have a new sense of our own fragility in life, and between thinking, how on earth have we tolerated so many people dying?
First of all, revisiting and hearing that encapsulation, I mean, my eyes just teared up. Hearing and thinking what I was going through each time I heard all those things. Feeling this impending wave coming and then seeing it come. I mean, it hit our hospital, hit my town hard in Boston. Our hospital filled. We had triple bed capacity. All of the things that we went through, have we processed it? No, but did we live it. And all of us did. I think there's a couple of things that are really striking about this experience. One is how differently it hit different communities by both age and race. At the end of the day, 76% of the spread came from people under the age of 50, but 93% of the deaths were in people over age 55, and even those were disproportionately among people of color. And that experience really meant people saw completely different things. Oh, this is just a flu and isn't such a big deal. And can even still to this day say, what's the big deal? Even after 500,000 dead and more coming, we're still on pace to add 100,000 more by this summer. And there's a troubling sense that we're really disconnected between the people who transmit the disease and the people who are going to get sick and die from it. All the cases we see now are hospitalizations 2 weeks later and deaths 4 weeks later. And again, we keep saying, oh, it's going to be different. It's not going to be so bad this time. And it keeps being terrible.
Is it just the numbers, or is it the fact that there is something almost uniquely awful about the way people have died, often alone, saying goodbye to their loved ones on FaceTime, holding the hand of a nurse who's in full PPE and protective gear, that makes the deaths of this pandemic, not just here in America, but worldwide, different in some way, more traumatic in some way?
Yes. And I think it's that, first of all, just people who die because they can't breathe. That has been a theme this year, and it is an awful thing. We had to witness it on video with George Floyd, and it brought us out of our, start to really confront some of the issues there. And similarly here, seeing your own family member knowing that they can't breathe, and then you're cast away from being able to see them, they're alone in the hospital. It is suffering on an extraordinary scale, and with an extraordinarily vivid impact. I think the other aspect of it, which is really important, it's in that word fragility you used, Katty, which is that this, for all of its focus on the oldest old being particularly vulnerable, this was a killer for people down to the youngest ages. It has raised the mortality rate of every group from ages 6 years upward. And that has meant that at one point or another, we have seen people who shouldn't die, dying or becoming extraordinarily sick. And it's made us aware of our own fragility in a way that we have gotten to forget about as a generation. Medicine and public health have had an extraordinary impact in making it so, dying before old age is an abnormality. It is not something we have to see and think about. And now we've had to for this past year, and that's really affected people.
things are getting better in America and fewer people are dying, but we look at hotspots around the world. I see the images for Brazil and it takes me straight back to this time a year ago. And now, of course, we're seeing the same images from India. And you have family in India, and I know that you've tweeted out that COVID has reached your family members. What are you hearing from them? How are things going there?
It's the same story all over again. We talk about, how their shortness of breath. And this infection in India has really, it's run through entire families. I have, dozens of nieces and nephews and cousins in Maharashtra state, which is one of the hardest hit states. And, my father's from a small village there. And the family there is scared. And you're seeing every single member of the household becoming infected from youngest to oldest and not knowing quite what to do. The other thing that I see is that there's both undertreatment and overtreatment. If you have the money to afford the private sector, people are often admitted with very mild disease and given treatments that should wait until they're really sick, remdesivir, steroids, things like that, out of a sense of, well, we should just do something. And some of that isn't very good and certainly very expensive for people and has caused a run on, really important supplies. You have shortages of oxygen and other needs really starting to appear. And then you have large numbers of poor people who simply have no access to treatment. Hospitals are backed up and people are scared to go to them with the crowds of people outside. And so, I'm hearing from people about both of those dimensions, and it's a replication of what we saw in the early days of Wuhan, and then in Daegu, South Korea, and then in Bergamo, Italy, and then in Madrid, and then in New York. And then, as I've reported on from North Dakota, it is one place after another, and it's a pattern that we still have to really take on as a global citizenry.
Atul, take a big step back and help us think about how our medical infrastructure has reacted to this challenge. Have there been big, bold changes that, even if they struggle to deal with the last year, will benefit us in the year, 2, and 10 years to come? Or have we been, amidst the pandemic, not really able to make kind of more systemic changes to our medical care and our medical system?
I'm really hopeful there. In the midst of crisis, it is extraordinary the ways that communities have come together to tackle this. And in particular, I think everybody has discovered the power of the public health community. In virtually every country, it has been systematically underfunded. The basic infrastructure of having people who are committed to helping the community address issues of disease and capture information like whether places have enough masks and have enough ventilators and have enough medicines and have enough diagnostic tests and now are getting the vaccines they need. We've all become incredibly acquainted with how important that work is and how much of a shoestring they had been functioning on. In the United States, we spend north of $12,000 per person per year on treating on acute illnesses, largely, our hospitals and our medical system. And we have had less than $80 per person for our public health, local and state public health sectors. And, we're paying the price of that now. The second thing is that the public health folks have gotten to know the healthcare delivery folks and the healthcare, the hospital systems and the doctors have gotten to know those public health people. And those connections, which really were often not there before, I think have been strengthened for the first time in many places. And that's going to create, I think, some lasting differences. And I really do think we'll come out of this with a much stronger platform and infrastructure for detecting when these problems are surfacing, to have testing solutions that move out much more quickly, and to have vaccines that can be ready to go much more quickly. I think we are less likely than ever to squander that opportunity.
Atul, I want to shift just a little bit to talk not just about the medical infrastructure, but the conversations that we are having in families and maybe among ourselves about death and dying. Because as you noted and as we heard President Biden say at the outset, at least here in the States, more Americans died in the last year than World War I, World War II, Vietnam War combined. And so death has been more present, and maybe there's a different kind of conversation that is happening as people think about their own lives and their loved ones. Have you been privy to that, and do you think we're thinking about death and dying in a different way, just on an everyday person level?
I have been privy to that. And what's interesting to me as a cancer surgeon, as well as a public health person, is how similar the experiences can be. There's this fascinating research work done by a Stanford researcher named Laura Carstensen from a couple decades ago, where she really looked at what happens as people become aware of the fragility of their life and see mortality around them. And what happens is that people really change emotionally. They shift from being focused on acquiring. I need more money, I want more status, I want a bigger house, I want, and building wider and wider social networks. And when you become aware of the fragility of your life, it's a different signature to how people behave and what they feel. They focus on deepening their relationships. They pare down their social contacts. They become less focused on acquisition and much more focused on a deeper, more intimate relationship with the people around them. And interestingly, they became happier. They were less likely to have anxiety, less likely to have depression. They had a resilience. And she thought this was age-related, Laura Carstensen, who did this work in the beginning. But then she was doing these studies in the early 90s, and HIV hit, that other major global pandemic that killed so many and continues to kill so many. And she found that their young people who developed HIV developed the signature of the older people who were in the study. Once they became aware of the fragility of life, they changed their lives and what they focused on, and in an odd way felt more purpose in their life and more connection to people. And then there came interesting data from 9/11, the attack on the Twin Towers, and the sense that there was potentially other attacks going on elsewhere, created a rapid change where people within those first few weeks did the same thing that people who face mortality face, which is that they shifted from focusing on, I want to be with more friends, I don't want to be with my family, I want to focus on my status, my money, my contacts, to really narrowing in on family, friends, people closest to them, whoever those people are, and wanting to deepen those relationships, and then felt a sense of purpose that when the crisis went away, they lost. Many people, after these crises, will revert to the old way. They'll go back to, wanting to hang out in the clubs at night and, blow off the family and do all that stuff. But others really do change, especially those who have endured losses. And I've seen it in the way people's lives have changed at multiple ages. People who've decided, I'm going to change my career. This is not what I want to be doing, or I'm going to leave my career to spend more time at home if I'm able, or I'm going to, be closer to family, or you've seen people really make major changes in their lives. And I think that's a indication of both our resiliency and some of the ways that the length of this and the experience of it has altered us.
One of the things, Atul, that you write about in Being Mortal is the dignity of death, how we can give people dignity at the end of their lives. And much of that seems to revolve around having open conversations with loved ones who are dying. There was a survey back in 2014 in America that showed that 90% of Americans say that it is important to have that conversation with a loved one about how they want to spend their last days, weeks, how they want to die effectively. But only 30% of people were actually having the conversations. Why is it so hard for us to take that step to have the conversation when we know the conversation is so important to giving them the right death?
Well, and it's not just the right death, it's also the right life all the way to the very end. I think it's partly heavily because we misunderstand what that conversation is. The conversation isn't about how you want to die. The conversation we all need as we get older or face any kind of danger like COVID has brought. The conversation is really about what matters to you in your life. The kinds of questions that I have with my patients when they come to see me about their cancer, especially if it's advanced, is what really matters to you? And to understand that, you have to unpack that people have priorities in their life besides just living longer. Those priorities change over time and are different from person to person. And the only way you can know what the priorities are in a person's life is to ask them. And if you don't ask them, the result is suffering, because then when you are facing needing help for whatever impairments you have or whatever serious illness you may be up against, you have a divergence between what people are treating you for and what you actually care about. And the kinds of questions you ask are things like, what are your fears if your health worsens? What are your goals if time is short? What's the minimum quality of life you'd find acceptable? What are you willing to go through, and what are you not willing to go through for the sake of more time? I remember one conversation I wrote about in Being Mortal was one where an older man said, well, minimum quality of life. If I can watch football on television and eat chocolate ice cream, that would be good enough for me. And if I can't, let me go. That was like the best living will ever. He told you about what really mattered to him, right? Yeah. And now, whether you're a family member or your doctor, you can understand now, what do I do if he becomes really sick? If I have to make decisions on his behalf about whether he should undergo surgery or not, or I just want to help him come to that decision, you go back to him and you say, do you still think chocolate ice cream and football and television are what really matter to you? It's one of my favorite dinner time conversations with people in the old days before COVID. You have people around and you say, chocolate ice cream and football and television, is that good enough for you? And people will tell you, like, I'll tell you it's not good enough for me. I want something more than that. And let me go if I can't have it. And I think we're scared because we think it's a different kind of conversation, like, tell me whether you want to be on a ventilator or not. It's not. It's about how do you live? What matters to you in life? And that's stuff you want to know from the people around you, no matter what.
I mean, to get specific, it's no secret to people listening to the show that I lost my mother at the end of November and I lost my father at the end of January. And I wish that with my mother, I had had the conversation early enough about what she wanted specifically when she wasn't able to advocate for herself, because I was with her when she died, and I suddenly found myself in a position of taking what seemed monumental decisions on her behalf and my family's behalf that I had never really realized I was going to take. When to start the morphine, when to put her onto a drip, how to change her. I don't know when we start the conversation. What do you say to people about when to start that conversation and how specific to get?
I think you start the conversation just out of curiosity with anyone around you. An absolute indication is that someone has had some kind of a health event that is serious, right? A new diagnosis of a major illness, a event that's put them in the hospital. And that's an occasion to say, boy, we've never talked about it, but you must be going through all kinds of decisions about what you will tolerate and what you won't tolerate, what you want to sacrifice and what you don't want to sacrifice here. Can you tell me? Because of all that I learned, I got to have that conversation with my father as he went through a tumor that was diagnosed in his spinal cord near his brainstem. And, his first answer was, what mattered to me was, he's a surgeon and he's like, I want to keep on doing surgery as long as I possibly can. That's what I really care about. And then the conversation over a couple of years, when that disappeared, right? He thought his life was going to end. And then he discovered, what he really loved about surgery was being with people and solving problems. And he became much more active in Rotary Club and charity work. Really took that place to the point that he, ran for district governor even as he was developing paralysis. And then when he reached the stage where he really was quadriplegic and couldn't do those things, then it was food and just connection to people that he still said, there's still things he loves life for. And these are what they are. And then there came a point when pain took those away and he said, just let me go. When pain became the dominant part of his life and he was either medicated into oblivion or enduring pain, then he could indicate that was where he had come to. And I think it's an ongoing conversation, but those first conversations opened the door so that we were comfortable having the later conversations.
Atul, what have you learned about race over this last year? And I don't necessarily want to set it up for anything overly profound if it's not there. But on the other hand, I know that at the very outset, you noted that there had been some big differences in the mortality rates and in the impact along race. So what, if anything, has this last year of really a very difficult circumstance taught you about race?
I'm so clearly still learning, but there is such an important confluence with George Floyd and the pandemic in realizing the systematic and long enduring ways that people of color and Black Americans in particular have endured unequal treatment in every part of society, from treatment by the police, in housing and jobs, and in healthcare. And I've scaled up testing operations and now vaccine centers. And building large-scale vaccination for city of Boston and other parts of Massachusetts, I've had to confront my blind spots in this issue. And where I might have thought this is just about messaging, how do I message to people who don't trust the healthcare system that they should come and get a vaccine? And instead, I've had to learn that it's how our centers operate at every level, how we make it accessible for people. You know, you can't count on people signing up and scheduling by smartphones. And we have developed systems where we even can, you know, first it was call centers, then it was handing out appointment cards by going door to door with people. And then it was engaging people who've been in the Black community and Hispanic community and the immigrant communities for a long time, who have been ignored and have built their networks and can do this work, and literally paying them to be the front line, to connect to the community and get people in to get vaccinated. And then it was even how we hired folks as our chief medical officer for our center, who was doing the vaccination and really capturing people. And the result was we went from people of color having 40% fewer vaccinations per capita than other members of the community in Boston. And for the folks over age 65 now, we've actually achieved a higher rate of vaccination in the Black community than the white community by a couple percentage points. I mean, we're basically up to 80% for the Black community and Asian community, and it's just below that for the white community. And we're a couple points below that for the Hispanic community. We have much more work to do for the younger people in outreach. But boy, I just learned so much, and it's very nitty-gritty, and it's about real engagement and connecting with people and learning from people and being chastised by people that I've never connected with before.
Your expression of humility there reminds me of a joke my brother-in-law tells, and he is a doctor. And the joke goes, what's the difference between a doctor and God? God doesn't think he's a doctor. And it makes me wonder whether... Took you a second, Carlos.
Katty, that is the best joke that we have had on the show. And so, Atul, you get credit for that. All the good Newton energy you're bringing to this conversation, you get credit for that. That is great. That is terrific.
I do love, I'm hearing it, but I am hearing from you a lot of humility. And I wonder whether both what you have just been speaking about how the pandemic and what we have seen around with the death of George Floyd has revealed the inequities for everybody to see in the system, in the healthcare system in the United States, in all of the systems in the United States. But whether, in a sense, doctors have been forced to realize the limitations of what they can do this year.
Yes, I don't think it's special to doctors, though. I mean, I think there's lots that's humbling about this experience, but I think as a deep cultural change that's been ongoing in healthcare for a couple of decades, about recognizing that we're far better off being transparent about what we know and what we don't know. You know, we're all imperfect human beings. Our skills are limited. Our knowledge is limited. And the pandemic really was extraordinary in the ways in which the entire community, you know, the entire world has dug into the research papers and questioned everything that people surmise from it. And there's been a great sort of way in which expertise has been recognized and tapped, but not accepted as infallible. We by far are not. We have facts we can bring to the table. Everybody has values to bring to the table about what to make of those facts. And it's messy, but I think it's made knowledge move so much faster and made it sort of built a level of trust that, the trust in doctors and nurses, despite our limits, has risen during this pandemic. And the trust in what public health can do has risen in this pandemic. And I think that kind of openness is really, really important.
Dr. Atul Gawande, thank you so much for joining us. What an interesting and important and timely conversation. Our best wishes to your family in India.
Thank you. And thank you for having me on.
Thank you, Atul. Well, Carlos, we've talked a lot about the George Floyd and Derek Chauvin case last week, and I was wondering a little bit this week whether we should have been talking more about that given the verdict up in Minneapolis. And actually it was so interesting to hear Atul there bring these two stories together for us.
Yes.
From a medical and social point of view.
Well, he spoke both to some of the fundamental cracks in the system, which sadly we all have seen and all have seen the risk involved there. But it was really maybe the thing, Katty, that he said that caught me the most was at the very end there where he talked about that word trust. And in some ways, that's something that you and I both know matters and is important. But it did just make me think about that word and that concept in so many different ways. Do we trust our doctors? Do we trust our public officials? Do we trust our data? Do we trust each other?
And do we trust ourselves to have that very hard conversation with loved ones who are at the end of their lives? Because
Indeed.
If we don't, then we will live with regrets afterwards. We hope you've enjoyed this episode of When Katty Met Carlos, a co-production from the BBC World Service
and OZY Media. If you've enjoyed this podcast, please leave us a review, tell a friend, and of course, don't forget to subscribe. Thank you, and we'll be back next week.